more smooth.
It's my fault.
Did they have enough staff? Did you notice?
So
Are you getting contact hour for this?
Do what?
Am I doing what?
Contact hours
Oh,
for this?
Yeah, 1.5.
4 or 6.
Oh, no.
On the clock? Or
Yeah, I'm
is
good.
that clocked out?
Yeah, you should clock in.
See you later.
Oh.
I can marry him. I don't know what. All right, guys. Anyone else know any other people coming? Probably not. Okay. Great. That's been the topic now. All right, well, I'm Steph. Dr. Williams' PA with plastic surgery, and we're just going to go over kind of what we're all about, some of the procedures, aftercare, and we're going to touch on the ERAS protocol as well, which you may have heard. So we'll just go ahead and get started. Here's a quick outline. We're going to talk about craniofacial team, do anatomy review, clefting, why it occurs, post-operatively, what we need to look out on the floor, and then the surgeries in general. So who makes up the craniofacial team? We have us, of course, the plastic surgeons and their PAs or NPs. Speech pathology, they're the ones that are going to basically be evaluating these kids throughout their life who have cleft palates, especially after the repair, to see as they grow if their muscles compensate, if they need speech surgery in the future. We have the dentist. These kids have a lot of dental caries just because there's a connection between the nose basically into their mouth, so they really struggle with that. ENT doing a lot of ear tubes for us. Hello, welcome. We just started, so no worries. A geneticist, a lot of these kids will either have syndromes or other genetic defects, so they do a full comprehensive evaluation, family history, anything like that to help the families understand more about this syndrome or about this situation, if they have other syndromes associated, and just are really a good source of information for everybody. I always learn a ton from all of their notes. The orthodontist, they're going to help us with our pre-surgical molding as well as maxillary expansion, really giving us a good prep for surgery. Social worker, a lot of these kids are kind of in some hairy social situations. Some of them are not at all, but their social workers just acts as a great resource, making sure they have all the supplies they need. At the craniofacial clinic, they always talk to every single patient, just making sure there's any resources or support groups they can help them reach out to. Then there's a nutritionist and feeding specialist. They're making sure these kids, especially at the very young age, are staying on track weight-wise. And then there's the pediatrician, who isn't themselves part of the craniofacial clinic, but they play a key role in our team because they're the ones that are seeing these kids a lot more frequently than we are. They're making sure they're staying on track. If they've been struggling with weight, they're getting weekly weights, they're reporting back to us, so they play a huge role as well. So there's Dr. Williams, who's chief of plastic surgery, who I work with. Then there's Magdalena Sodanska, her nurse practitioner is Jocelyn, and then Dr. Colin Brady, who is new to us. He came through with plastic surgery fellowship. Then he went away for a year to do his craniofacial fellowship, came back and worked with us, and his PA is Cal, who used to be Dr. Burstein's PA. So let's do a quick anatomy review. The palate itself can be a little confusing because you can divide it in a couple ways. But basically this image is showing a cleft of the soft palate, which is basically the back. And there's no bone underneath it. The hard palate, that's the word hard, had that bony structure behind it, so in itself is hard. And that's more the front part. So here's a cleft of both the hard and soft palate. And you can have either just the soft palate cleft or just a hard palate. And here's just a side view. You can see that bone right here that I'm talking about. So that would be the hard palate, and the back there, which is just soft tissue, is the soft palate. Then you can divide it into primary or secondary palate. And this basically goes along with how it develops in the womb. So primary palate, there's a little area, a little divot right here in the roof of the mouth that's called the incisive foramen or incisive fossa, and that basically acts as that dividing point. Anything in front of that is a primary palate, and anything behind that is a secondary palate. Here's a review of just some examples. We have a normal intact palate. Then you can see that first kiddo has a cleft lip on one side, and they also have that cleft palate that you see going all through here, and it is complete since it's going through the entire palate. And this is a bilateral cleft lip and palate. Then with the cleft lip itself, you can have a partial, also known as incomplete, or a complete cleft lip, and that's going all the way from the alveolar tissue all the way up to the nasal base. So again, here's some examples we can kind of run through. It's just good practice. That one on the top is a normal intact palate and lip. Then we have a unilateral cleft of just the soft palate, so just the back of the palate, and it's really only on one side. Then we have a unilateral cleft lip on B. The palate is intact. A unilateral cleft lip, and then a incomplete cleft palate. Here's a complete unilateral cleft lip and palate going all the way through. This is a bilateral cleft of the soft palate. You can see here that was unilateral, and this is just affecting both sides. Here's a bilateral complete cleft lip. Palate is totally intact. Bilateral cleft lip and palate. Incomplete because it's not going the entire through the entire palate. And then bilateral cleft lip and palate complete. So there's lots of different categories and names for them, but just to kind of give you an idea when you see that on the charts. Here are some famous guys that have cleft lip and their palate. So just an example of kind of, you can still be successful. They really serve as an inspiration for a lot of kids who are growing up with this and have scars and that kind of thing. And here's some cute little animals that have them as well. So animals. So let's talk. I'm sorry.
Who's the third guy? It was Peyton Manning. Who is that?
Jesse Jackson.
No.
Oh, Joaquin Phoenix.
That's why I was like,
Is that how you say his name?
Yeah,
I
Joaquin.
didn't never notice that.
Yeah, you can see. I don't think it was
that big.
Yeah, it was very minor, but you can kind of see
I
that
can see
scar a
it
little
where it
bit.
is.
Yeah,
You
so
can
it's
notice
kind
it
of cool.
right here. Okay.
Good to know.
Okay.
Then we have these little cute guys. Excuse me. So what causes clefting? So basically there's different factors involved. The primary palate, which we talked about, is anything in front of that incisive fossa. That is in itself its own process when development from the embryo, and then we have the secondary palate. That's kind of a different process as it develops in the womb. So you're having a failure fusion of these different prominences. Obviously this is super early in life. There's two nasal prominences, lateral and medial on each side, and they are supposed to then come together, and if they don't, you're going to have a cleft. Then we have the maxillary prominence, the mandibular prominence. Not super necessary, but just again to give you an example of when this occurs. In the secondary palate, again, different process, and that is completed later in the second trimester. So most are not associated with a syndrome. So usually they can just kind of be a fluke. It's a perfect storm of different factors and influences, but you know, most of the time it's not, you can't really do anything about it. It just happens genetically in very, very early stages. It's just going to happen regardless. But then there are as well hundreds of different syndromes that are associated with cleft palate. So not necessarily all these syndromes have a cleft palate, but there is definitely some parallels between them. Hello. Some of the common ones you may hear is the Vanderwood syndrome, Valocardial or Q22 syndrome, Pierre-Robin. They're the ones with a small lower jaw. Goldenhar, Treacher-Collins, Stickler, Aperts. A lot of these kids are going to have cleft palate and or lip as well. There are risk factors, things that influence, give it a greater chance of occurring. There's steroids during pregnancy, different retinoids, anticonvulsants such as phenytoin, benzodiazepines can, methotrexate, and also infections during the first trimester when that development is occurring that affects having a cleft or not, like rubella and toxoplasmosis. Smoking can play a role, alcohol, a mom that has a high BMI, not enough folic acid intake, If you have diabetes prior to pregnancy, that can increase your risk, and also developing gestational diabetes during pregnancy. Again, it's usually not because this mom smoked during first trimester, then they're automatically going to have a cleft kid. And some say, they had a couple glasses of wine and this mom feels so guilty, like they're the ones that caused this cleft. That's usually not the case at all. Do these factors maybe help make it happen with, things that are already kind of in place, and you're kind of almost, doomed, if you will, otherwise, and then these are going to make it like a for sure thing. But it's usually not because you smoked that one cigarette, this is happening. But again, just things that seem to influence the development. Family history, if you have a parent, of course, that has clefting, you're more likely to have that, or any strong family history of clefting. If you have a previous child that's had a cleft, you're more likely to then have another child with a cleft as well. So cleft lip, whether they have palate or not, plus or minus palate, occurs in 1 in 700 births. So relatively common. It's actually one of the most common congenital defects, I believe, behind club feet, I believe is the number one. But it's definitely the number one in terms of anything craniofacial-wise or in the skull head development. And then isolated, just having cleft palate occurs in about 1 in 1,000, so a little bit less common. Here's just some epidemiology facts to kind of know. Asian patients are the most common to have clefting. Males are more common than females in having lip and palate, and then that isolated cleft palate is more common in females. If you have a unilateral cleft lip, it's most likely going to be on the left side, and unilateral is a lot more common than having a bilateral cleft lip. Does anyone know or have an idea about the average number of surgeries a kid will have if they have cleft lip and palate throughout their life? 10. Okay, well, some of them have 10, but the average number is 5. So definitely we have kids that have 15. I mean, it can be a lot. But first of all, you're going to have NAM, which we'll talk about, but that's that pre-surgical orthodontic molding there for cleft lip. So you're going to have the cleft lip repair, cleft palate repair, a pharyngoplasty or speech surgery if needed, again, whether the speech pathologist basically tells us if we need to do one or not, alveolar bone grafting, and then they might need jaw surgery as well. In addition to those are the kind of the big ones throughout life. There can be revisions. Say someone just has a cleft lip, they don't need really these other things, but it was a bad bilateral cleft lip, they need a couple revisions throughout their life. So it can definitely add up for sure. So NAM, or nasoalveolar molding, the orthodontist fits these and kind of goes through this process prior to surgery. Stretches out tissue, gives us the best chance to have the best repair possible, and it's super important. Sometimes we get kids from other states, they don't have the same resources in terms of a craniofacial clinic like we have here. They didn't have NAM. It really, really makes a huge difference when they don't have it. And it's definitely a lot harder, a lot tighter, pulling in tissue. It's definitely more difficult. I'm sorry. So just in general, we're going to go over kind of some things to consider post-operatively with these kids, mostly on the floor. So you always, of course, want to look at the respiratory status. We are dealing with things that are near the airway, like when we repair the palate. So you're always looking, basically, are these kids struggling to breathe or not? Are they have too much maybe medication after surgery that's still with them, or they're really struggling? They just have signs of poor breathing. And then does anyone know some signs of aspiration of secretions of milk, which happens on occasion with these kids? So basically, you're just going to look for, again, kids struggling, any signs of decreased oxygenation. So they aspirated on milk, or just their secretions after surgery. They're coughing, they're having, labored breathing, delayed calf refill, all these things to kind of look out for. Feeding, so nasal regurgitation is common, especially if they have an unrepaired cleft palate. So things to help with that are encouraging parents to feed them in an upright position, and there's no need to really suction things out. If they are having stuff come out of their nose, it'll really clear on its own. But it is common to see them, drink some, and then boom, it's coming out of their nose. A lot of, especially again, unrepaired cleft palate, they're trying to suck, their bottle, and they're swallowing a lot of air, so they'll have a lot of, air, gas, burping, all of that. And so just really the only thing to do is just to frequently burp them. So, encourage parents to walk around, really burp them as frequently as possible to help get some of that air out. Suctioning in general for all these surgeries, you just want to be careful. That's the most important thing. Expect bloody secretions, bloody saliva, some old blood draining out of the nose. If it's, of course, frank blood, just non-stop, call us immediately. But generally, it's kind of just that old blood, or they just ate and there's a little irritation, a little bit of fresh blood in their saliva, and that's totally normal. You can just help them, just suction kind of right around the mouth or the nose. You don't really want to go inside the mouth at the time because you don't want to damage any of the areas we just fixed. So let's talk about cleft lip repair first. Again, that's done at age 3 to 5 months. Hopefully they have NAM prior to that if necessary. We use Marcaine in the OR. That lasts 6 to 8 hours, so say that by the time they get to the floor, that should be at least 4 to 5 hours of basically being completely numb. So yes, it's going to be tight feeling. They're going to feel different. They're going to be angry about being in the hospital, having their welcome sleeves on, all these things, but truly they should really not have any pain for at least a couple hours. Of course, that will wear off, and it should be more of that soreness, tightness from the swelling. We use all dissolvable sutures, and then we use skin glue as well. If it's a bilateral cleft lip repair, and we have a lot of nasal collapse after surgeries, we're pulling that tissue in, and really there's not a lot of nasal patency. We will occasionally put these stents in, so that's just an example kind of what they look like. We will suture them in. They hate them, of course, but they do really help keep that structure there until things are healed up a little bit. So we keep those in basically as long as they'll stay in, but it's generally a couple weeks. So after surgery, again, they'll have those welcome sleeves, which they just love. Toradol, unless they're, if they're 5 or 6 months, Toradol is fine. Motrin is fine. If they're, 3 months old or they're a preemie in 3 months, that, usually pharmacy doesn't love when we use Toradol, but it might be there as an option. Tylenol, of course, is a mainstay as well. Expect bruising a little bit or some swelling. Again, nasal bloody drainage, and then it kind of dries onto the glue, and it cannot look the prettiest, but all these are kind of normal. That will wash off with bathing. Don't avoid prone position. Again, we want to keep that area that we just repaired nice and safe. Bottles are okay, breastfeeding is okay, pacifiers are okay. It's a little bit different per physician, but in general, all those things are okay for just when we're doing the lip repair. So what if this kid just comes back from a lip repair, they're doing great, but they also have a cleft palate, of course, that is not repaired yet. What do they do feeding-wise? So they'll probably be, struggling. They're not going to be normally taking, a normal bottle. And we need to understand really the role of the palate to understand, what we can do to help them feed. So it separates the mouth from the nasal cavity. Normally, with someone who has an intact palate, that soft palate in the back of the throat moves up and closes off that passage into the nose when they swallow. So it's a closed system. There's negative pressure. They're able to suck from a bottle or a nipple. When we have a cleft there's air going back and forth. There's not really that closed system. No negative pressure can really occur. So there's a couple different bottles that I'm sure you guys have seen and are probably more familiar with them than I am, but I'm just going to go over them briefly. So anyone with an unrepaired cleft palate probably is using one of these bottles. So we have the Mead Johnson, which basically is very simple. There's no valves or anything. It's just a soft nipple and a soft bottle. So the parent is controlling the flow and squeezing the bottle as the baby kind of tries the sucking motion. Then we have the Haberman feeder. That has a one-way valve. It's a large compressible nipple. The parent can help by squeezing the bottle, but usually the child is able to get some out on their own as well. We have the pigeon feeder that fits on most bottles. It has a Y-cut tip in the nipple. It's thin, it's compressible, and basically the baby is controlling the rate of feeding. They press their tongue up against the nipple to whatever structure they have in terms of incomplete, complete palate, whatnot, and they're basically just kind of teasing that milk out. And then there's the Dr. Brown's feeding system. They have a whole series of many things that is nice because you can kind of change things as they develop and their palate's repaired and all of these things, but they basically don't require any suction if you have that valve in. Discharge criteria, we just want to make sure they're basically drinking okay, making sure they're not going to be dehydrated once they go home and don't have their IV fluids. They're not having any fever and their pain is well controlled with Tylenol or Advil if they're old enough. Usually these kids are going home in less than 24 hours or around 24 hours. Some of them, especially if they're just unilateral, incomplete, and have an early surgery in the morning, some of them we even get them home that evening if the parents live close by and they're comfortable going home. They'll follow up in a couple weeks. So we have the cleft palate repair. So does anyone know why the cleft palate is repaired at that age of 8 to 12 months? Like why isn't it 2 years? Because the thought would be, oh, they have more tissue to help close. Does anyone know why we do it so early?
Is it softer and the bone's not as hard, or?
No, that's actually a good thought. Did I hear another?
To prevent aspirations.
Yes, that plays a role. So we're helping with feeding, but the number one reason why we do it in that specific time frame is speech, because that's going to be right before any major speech development. So we really try to get them in there before they're starting to use those speech muscles and everything to give them the best chance, basically, of not needing speech surgery in the future. So cleft palate repair is done 6 to 12 months. It varies from craniofacial center from another. Some of them do wait more of that 16 months, but everyone here tries to get it done in that time frame. We're helping the child eat better, getting back on track if they're falling behind. It's a lot easier to eat, of course, if they have an intact palate, and then speak more normally. We use Marcaine again. These kids should be completely numb. We do a complete block of the palate. The only thing we don't do any local anesthetic for is the tongue stitch. So that can be the bloodiest, and that can be the most painful because we put a stitch in the tongue at the end of surgery, and then in PACU when they feel that the airway's good, the kid's ready to basically go to the floor, they'll trim the tongue stitch, and it's just the thought of having a stitch in your tongue is just painful, but it's all about the airway. We use dissolvable sutures. We use Surgicel, which we'll talk about in a second, and then sometimes we even put Dermabond in there as well. So Surgicel, sometimes I'll get calls from the floor and they're like, there's this big clot that was coughed up or something dangling in the back of the throat. We essentially, if there's a cleft of the palate, we're moving the tissue to the middle and sealing that up, and then leaving 2 little slits kind of on the side. There's still closed layers behind that, but that superficial layer that you see, we leave open on the side, and we stuff this little material in it. This is what it looks like when it's dry, so you probably won't see it like that, because as soon as we put it in there, it's soaking up saliva, blood. It's helping with pain control because it's not a raw surface, and it's also helping stop some blood, and it promotes healing. Basically, that tissue will heal up on its own on the side. Sometimes it's just taken in by the tissue, it kind of dissolves. Sometimes as those tissues close up, it's spit into the mouth. Sometimes it'll be dangling. Sometimes the baby will be feeding and it comes out and they're coughing on it. They can swallow it. It's completely harmless. It's made of cornstarch. But it can be kind of a frightening thing if, say, your baby's crying and you see these 2 black blobs in which that's kind of what it looks like. It's not a palate repair, but it's the only picture you can find of it in surgery. And they think it's dead tissue or a big blood clot when it's not. So just to kind of be aware, you can, if it's dangling down, you can trim it. It's not recommended that you pull it because you don't know really how long it is, and it could be really serving its duty, and you don't want to pull the whole thing out. Again, if they swallow it, totally okay. Again, expect bloody drainage coming from the mouth, nose, all these things, especially with the palate, since we are having that raw surface there. Yes, we put the Surgicel in it, but it's still not a completely closed system, so there's going to be some bloody drainage, especially with crying, anything that's getting the blood pressure up. We will prescribe nystatin. Thrush is a huge devastation to any palate repair. It can just make the tissues friable and a palate will come apart. So we go ahead and prescribe nystatin since it's pretty harmless, and just to keep Thrush far away from them. They'll have a nasal steroid spray, Nasonex. They'll have those lovely welcome sleeves again. We don't want anything going in the mouth, the fingers, anything that could damage the repair. For pain control, we're going to be doing the ERAS protocol, which I'll touch on in a second. Suctioning, again, same thing as before, just don't stick it all the way in the mouth because we don't want to harm things. Feedings, so no bottles, no pacifiers. There are certain kids, like when I showed you guys those pictures in the beginning of they have a soft palate that was repaired or something like that. They were like, you know what, okay, bottles are okay, we're not worried about it reaching all the way back there, but just say no bottles, and then if Dr. Williams or other physicians say specifically, you know what, it's okay, let's let them do bottles, we're not worried about it. But in general, no bottles, no pacifiers. You can use syringes, even if bottles are okay, sometimes they prefer syringes in the beginning. Anything to get fluid in them, we're happy with. And then stage 1, 2, baby food, we just want kind of the spoon to go to the lips and then kind of dumping it in versus scraping the roof of the mouth. We do allow little soft teething toys. They're, you know, these little soft, little nubby, rubby things, or rubber things is fine. If they're, you know, obviously the parent's watching them, they're just having it right there at the tip of their mouth, that's fine. They're usually in a teething stage, so they can kind of be miserable without them. Or those little toys that kind of are like washcloths, little animals that are soft. We just don't want, again, things going all the way in and touching the palate. And no hands. No hands. Okay, so ERAS. So that stands for Enhanced Recovery After Surgery. It's used a lot in the adult surgical population, and it's starting to infiltrate down to the pediatric world, and we've been doing this since April. It's been extremely successful. So what we noticed a couple years ago is that some of these kids getting morphine or a lot of high set on the floor, and they're, you know, obviously very, very young, and maybe it's the correct dosage according to guidelines and pharmacy and all these things, but they're so young, maybe they metabolize things differently. You can have things, kids that are hyper-metabolizers or hypo-metabolizers of them, and this is their first time usually getting narcotics. We have no idea what their reaction is going to be to them, and, you know, there's a couple of incidences where a kid was just lethargic, listless, and, you know, up to the ICU, rapid response, and up to the ICU you go. And, you know, the last couple years, we've been really taking it down narcotic-wise, no morphine, just high set, basically as needed. We implemented Toradol, all these things, but we really wanted to kind of create a good structure of things to follow, so it was very unified, uniform throughout the specialty, and so we thought that ERAS would be a good protocol to kind of go on and then make it our own. So it's, you know, every ERAS protocol is a little modified based on what surgery is being done. So our goal is no narcotics at all, just basically for the health of the kids. There's a lot of risks, like I talked about, respiratory depression, all these things. You know, and also we don't want them knocked out the whole day and then they're not drinking, and then they're staying longer, and, you know, we're worried about them being dehydrated because they're just knocked out. Of course, you know, it's just basically structured. Every kid is different, every situation is different. Our goal is no narcotics, but, you know, there's definitely incidences where narcotics have been needed on an as-needed basis. But we kind of just go in planning and hoping for no narcotics. So prior to surgery, they'll get a loading dose of Neurontin, also known as gabapentin. Then during surgery, anesthesia has their own protocol that's in conjunction with part of ours. They have specific parameters that they follow. They do things like Precedex, they do Toradol, they do Decadron. They don't do any narcotics during surgery. You know, again, there'll be as needed things prescribed like fentanyl for agitation, that kind of thing, but they try to avoid them if necessary, unless necessary. And then after surgery, they're going to get Neurontin, gabapentin as well, but at a little bit lower dose, the maintenance dose, which is 10 milligrams per kilogram. They'll take that 3 times a day, and then we'll also prescribe Tylenol and Toradol, which then kind of goes to Motrin when they're ready for more PO. So either Toradol or Motrin Advil is fine. I tell parents once they go home, because they'll go home with a prescription of Neurontin for 2 days, I just tell them an easy way to remember is breakfast time, lunchtime, dinner time, do your Neurontin dose, a Tylenol dose, and an Advil dose. You can do all 3 at the same time. They're doing all completely different things, just to kind of, you know, just cover all your bases. If they want to stagger them more or anything, that is completely fine. It's up to them. But as long as they're getting their Neurontin spaced out 3 times a day, we're happy about that. And then I tell them if you do those 3 kind of meal medications, then